Thank you for having me. I'm not an infertility doctor. I specialize in minimally invasive GYN surgery, but I see a lot of patients with endometriomas, and I feel like it's becoming increasingly difficult to counsel them because there's a lot of data coming out, and it's kind of confusing to get through it all and make sense of it. So let's begin. We have a lot to cover. I have no financial disclosures. So we're going to talk about the impact of endometriomas on ovarian function, the impact of endometrioma surgery on ovarian function, the impact of both on pregnancy, and also talk about some methods, surgical methods for optimal preservation of ovarian tissue. So I'm sure everyone in this room knows what endometrioma looks like. We see endometriomas in about 20 to 40% of patients with endometriosis. Endometriomas usually imply pretty horrible endo, usually stage 3, stage 4 endometriosis. So what do we know about endometriomas at baseline and their impact on ovarian function? So endometriomas create, or within an endometrioma, there's all sorts of, on a basic science level, looking at the cellular and molecular makeup of the contents of the endometrioma. There's free iron, reactive oxygen species, lots of inflammatory molecules that can impact the surrounding tissue. There's a very thin layer between the cyst itself and the surrounding normal ovarian cortex, and we think that that can have all sorts of changes or impact on the surrounding, again, normal tissue. It can induce DNA mutations, impaired angiogenesis, changes in gene profile, hormone receptivity, hormone biosynthesis, and creates, again, this oxidative stress and iron. We know, looking underneath the microscope at the normal ovarian cortex around the ovarian endometriomas versus that of teratomas or cystadenomas, we see around the endometrioma decreased follicular numbers, less frequent follicular maturation up to the antral stage, and increased microvascular injury and blood perfusion. There's other ways of measuring ovarian reserve, the most common things being looking at the antral follicle count, anti-Müllerian hormone, also ovulation rates. So again, this is just endometriomas at baseline. This is not talking about surgery. So there's lots of studies that have looked at antral follicle count and in endometriomas. And these are 3 studies listed here, 2 of which are statistically significant, but I will bring up that there's a pretty wide standard deviation. But in general, it appears most studies would indicate that there is a difference in the antral follicle count in affected ovaries versus healthy ovaries. Antral follicle count, though, definitely has some issues. It is subjective. There's no way you can blind an ultrasonographer to a 5-centimeter endometrioma, and it is sonographer dependent. So anti-Müllerian hormone is slightly more objective way of looking at ovarian reserve, again, in patients with endometriomas. There's a nicely done study in 2013, a prospective cohort looking at 30 patients with endometriomas. 15 of those were unilateral, 15 bilateral. The mean cyst diameter was 4.3 centimeters, and all of these patients had an age-matched control without an ovarian cyst. And there was a statistically significant difference in the AMH in those patients with and without endometriomas. The patients with endometriomas had a much lower AMH than the controls. Okay, so now let's talk about surgery. So we already know that endometriomas can impact function, but what about if we then throw in surgery? Again, looking at the pathology from ovarian tissue that has been removed at the time of cystectomy, in more than 50% of pathologic specimens from ovarian cystectomies for endometriomas, more than 50% of the time, there's normal ovarian tissue around. That's very different than doing cystectomies for other non-endometriotic cysts, where usually much smaller percentage, 6%, will have normal ovarian tissue around. And we all know from doing cystectomies and endometriomas, they are sticky. They are tough to get out sometimes. Sometimes it's really difficult to find that plane, so it makes sense that you would see this corresponding in the pathologic specimens. Also, there are some studies, nobody likes to, air their bad outcomes, but there's several studies looking at actually the risk of ovarian failure after cystectomy for endometriomas. The 2.4% risk of post-surgical ovarian failure is from a study in 2006. It was a retrospective analysis of all patients that had undergone surgery for endometriomas and followed them for an 8-year period afterwards. I'm sorry, it was 8 years after the surgery. And 2.4%, or 3 of them, it was 126 patients, had immediate post-op failure. Of those patients that had immediate menopause, there's 3, all had bilateral. 1 patient had multiple endometriomas on both ovary. They were all in their 30s. And aside from that, there was really not much different. Another study in 2011 prospectively followed 302 patients over 14 years who had undergone laparoscopic surgery for endometriomas. Again, the mean age was in the 30s. They followed them for an average of 8 years afterwards. In that 8-year period, 14% of patients entered menopause. The average age of menopause of those patients undergoing menopause was 45, which we know is much younger than the average age typically that we see in a normal population. Those people that did go into menopause, those that had bilateral endometrioma excision, the average age of menopause was 42. In those removing unilateral, the average age was 47. And of those patients that did go enter into menopause, it was a very similar number to the previous study. About 2.3% were considered premature ovarian failure. So it's a real risk that often is not recognized and not well reported. Okay, so let's look at the impact of endometrioma surgery on ovarian reserve. Let's start first with antral follicle count. So there's a recent meta-analysis in 2014. It included 13 studies. 3 of those were randomized control studies, 8 prospective cohorts, 2 retrospective. And what they saw that there was no change in the antral follicle count for affected ovaries. So those ovaries with endometriomas, there was no change in the antral follicle count before and after surgery. But the affected ovaries did have a lower antral follicle count compared to those, the unaffected after surgery. But there were some problems with this study. You can see from the results that they're kind of all over the place. So take that with a grain of salt. And I think the same issues with antral follicle count that I mentioned previously. It is ultrasonographer dependent and can't be blinded, but the results are a little bit, there is large heterogeneity among studies. Also, now looking at endometrioma cystectomy on ovarian reserve by measuring anti-Müllerian hormone. There was a meta-analysis in 2012 where 8 studies were included, including 237 patients. The mean endometrioma diameter was 3.7 to 6.7 centimeters, and there was a statistically significant decrease in AMH after ovarian cystectomy. They then further looked at this data to try and exclude any confounders, and they controlled for age, so they only looked at the patients who were age less than 40, so excluding those patients who are 47, like maybe they're more likely to have a bigger decline, so they only looked at the patients who are less than 40. They then also looked at size, so maybe size has something to do with it, and only looked at the endometriomas greater than 5. And also looked at the baseline AMH. So maybe if it's real low to begin with and you then peel out an endometrioma, maybe they're more likely to have a bigger decline. But even controlling for all of those, there was still a statistically significant difference and decline in that AMH level. So it appears that the rate of AMH decline does not correlate to age, laterality, cyst diameter, or the number of primordial follicles at the get-go. So we care a lot about AMH and antral follicle count, and it gives us some sort of numerical numbers to work with and counsel patients, but what we really care about is how does this translate to conception and pregnancy. And it's very confusing, and one study says one thing and the next says another, and it's a bit all over the place. So there is a lot of question and a lot of research still to be done. I am going to talk about this meta-analysis, recent meta-analysis in 2015, looking at the impact of endometrioma on IVF and ICSI outcomes. So not spontaneous pregnancy, just IVF and ICSI. And this looked at subfertile women with endometriomas who have or have not undergone surgery and the plan for IVF or ICSI. Again, 33 studies were included, 30 were retrospective, 3 randomized controlled trials. Compared to women without disease, those women with endometriomas, while doing IVF and ICSI, not spontaneous, had similar live birth rates, similar clinical pregnancy rates, lower mean number of oocytes retrieved, and a higher cycle cancellation rate. Compared to women with no surgical treatment, women who had their endometrioma surgically treated prior still had a similar live birth rate, clinical pregnancy rate, and mean number of oocytes retrieved. So, similar outcomes in women with and without disease. Surgical treatment did not appear to alter that outcome, and it appears that a reduced ovarian reserve may be attributed to the presence of the endometrioma more so than the surgery itself. This is another study looking at the long-term reproductive performance. This is they looked at the outcomes by questionnaire, so take that with a grain of salt because we all know the problems inherent with sending out a questionnaire and marking off your answers. But they looked at 68 women with previous endometrioma surgery, and they had an age and weight match control. And in general, this doesn't have the control group on there, but compared to the control group, women with endometriomas had a much lower conception rate. It appeared that surgery the spontaneous pregnancy rate did not appear to change in this study with surgery. Surgery did improve this is different than the last, but surgery did not appear to have, this is different than the last study, where in this study, the surgery did appear to improve the success with IVF. But overall, the pregnancy rate was much lower than, again, a control non-endometriosis population. So is there anything that we can do to potentially minimize damage to ovarian tissue? There's a lot more studies coming out about this, and I don't get much into the nitty-gritty details, but as Dr. Sechkin had alluded to yesterday, it makes sense if you fry an egg. That's probably not so good for the egg. So there are several studies comparing bipolar to suturing to using various hemostatic agents, and it does appear that suturing and hemostatic agents are probably somewhat protective for a reduction in ovarian reserve, which again makes sense if we're not frying ovaries. And in all of these studies, there does appear to be there's a greater rate. All of them with cystectomies in general. There's always a decline in ovarian function, but it appears to be less with the hemostatic agents or with suture. So it's a very difficult, lots of things to take into consideration when you're counseling a patient, and you have to take various factors into consideration. Number one, the symptoms. Even if we know that it can have potentially negative impacts on ovarian function, if someone is horribly symptomatic, then we often have to intervene with surgery if their symptoms can't be controlled medically. Also, size and appearance. If there's any question for malignancy, then obviously we're not going to, or within reason, manage them conservatively. Also, depending on their childbearing wishes. If you can control someone's symptoms medically, then you might be better off delaying the surgery because we do know that repetitive surgeries, there's a high risk of endometrioma recurrence. So if you do a resection of an endometrioma, and then 2 years later, that's when they want to get pregnant and they have a recurrent, then repetitive surgeries definitely have a big negative impact on ovarian function. So you have to take that timing into consideration. Also the feasibility of assisted reproductive technology. There's a lot of issues that came up with the concern for endometriomas, whether you might seed the belly, whether you increase the risk of developing infected endometriomas by going through those endometriomas, if you can rupture them, if you contaminate, the embryos with that endometriotic fluid. There's a recent study that came out looking at those things, and really those risks are extraordinarily small. But one thing that is often true is the feasibility. If you can't get to the ovaries because their pelvis is cement and the ovaries are located in some crazy position, then you might not physically be able to access the ovaries. So, in conclusion, endometriomas are associated with a decreased ovarian reserve at baseline. Surgery further decreases that reserve, and it seems to be irrespective of size, age, laterality, surgical technique, or skill, though there are some things that can be done to minimize the effect. Patients with endometriomas have an overall decreased spontaneous pregnancy rate. Assisted reproductive outcomes may not be affected by surgery, and we really have to be very careful with the way we counsel our patients and use very careful surgical technique. And that's it.